Okay, hello everyone. It's time to start this webinar. Thank you for all the attendees for joining this webinar. Some may be celebrating the Islamic events of Eid al-Adha today, but we the ASPA celebrates and enjoys diversity and inclusivity. I'm Soichiro Obara from Japan. I'll be chairing today's ASPA webinar. Today we have our ASPA Research Special Interest Group webinar with honorably having three distinguished speakers. Next, please. Before commencing main portion of the webinar, I just want to introduce our fabulous members of the ASPA Research Special Interest Group. We currently have these members from Turkey to Japan. Next, please. Currently, we have been engaged in conducting a multinational multi-center collaborative project to examine perioperative morbidity through Asia, which is named as Teaching Asia Study. The multi-center collaborative research project models the European apricot study. Next, please. We have completed a pilot study among 10 centers of the main national coordinators, so we are about to commence the main study with recruiting as many patients and collaborating centers. The current protocol is issued on Medical Archive. Anyone can look through the protocol through the website. Kindly scan the QR code. If you had any interest in joining in this project, feel free to contact me through this email address. Any institutions or anyone is very welcome and your participation is highly appreciated. Next, please. Okay, let's move on to today's main portion, the Research Special Interest Group webinar. Today, we are very pleased to have three moderators, me from Japan, Professor Fauzia Khan from Pakistan, Professor Ekta Rai from India, and an IT support member, Dr. Teddy Fabira from Singapore. Next, please. As shown here, we are very honored to have three distinguished speakers, Professor Su-Wei Choi from Hong Kong, Professor Dong-Kyu Lee from Republic of Korea, and Professor Kazuyoshi Aoyama from Canada. We, the Asian Society of Paediatric Anesthesiologists, ASPA, faithfully show our best gratitude to these three invited speakers here for their great contribution to today's webinar. So, the audience, you may have some difficulties in conducting clinical research while you must be busy in clinical work in the operating room or outside the operating room. That's why we scheduled today's webinar. We hope you will be able to take any home message from the lectures and will be motivated to conduct or join some clinical research project to solve your clinical questions. So before commencing the actual webinar, I quickly run through some house rules. As for the question or comments, you can send via the Q&A section. You cannot use the chat and raised hand functions. Our moderators highlight your questions to the appropriate speaker during panel discussion. Some questions will be answered by text with the appropriate speaker in the Q&A section. Next, please. We will ask some questions with use of a poll question system. Once a poll question comes up during the lecture or before the lecture, you will be prompted to answer the poll question. You will have 30 seconds to respond and submit your answer. Soon after collecting your prevailing answers, we will share the results. After the result is shared, you may close the system so that you can come back to the lecture by the speakers. Next, please. As for the certificate of attendance, it will be automatically generated and forwarded to you after you submit the post-webinar survey. The post-webinar survey will be emailed tomorrow. Please make sure that you have put your correct full name and email address to the post-webinar survey. For those who wish to watch this webinar recording at a later date, kindly visit our Asian Society of Paediatric Anesthesiologists webpage, follow us on YouTube and like us on Facebook. Next, please. Okay, now I'm very pleased and honored to introduce one of our co-moderators, Professor Fauzia Khan. She has long been contributed to the development and safety in pediatric anesthesia in Asia. She is currently working for Aga Khan University Hospital, Karachi in Pakistan. She is also working for many anesthesia societies, including the World Federations of Societies of Anesthesiologists as a chief at Diversity, Equity, and Inclusion Committee. She is one of the leading clinical researchers and educators in the field of pediatric anesthesia in Asia. Here, I would like to pass my roles to Fauzia. Fauzia, please come up to this stage.
Thank you, Dr. Bara. Now it is my pleasure to introduce to you Dr. Soy Y Choi from Hong Kong. Dr. Choi is a research assistant professor, Department of Orthopedics and Traumatology at the University of Hong Kong. She is also a research associate of oral and maxillofacial surgery in the Faculty of Dentistry of the University of Hong Kong. She trained as a biochemist in UK and specializes in the search for biomarkers which signal early disease and can aid in early diagnosis. She has published over 130 research papers, and her research interests are in chronic disease and statistics in medicine. She will talk to us on the trials and tribulations of medical research. We have some poll questions before she starts a lecture. The first poll question is, should randomized trial always be considered level 1 evidence? And there are two choices. Please go ahead and mark. I'll just go through the other two questions. Second question is, what should researchers do if their hospital does not have an institutional review board? And you have to give one choice out of the choices given below. Go ahead and do the study first, or seek help at the city level, register the trial with clinicaltrials.gov, and either a combination of A and B or B and C. Our third question is, should clinicians be doing research? And again, there is a yes and no. We have 30 seconds for you to answer these poll questions. Okay, we have some results. For the first question, should randomized trials always be considered level 1 evidence? 49% have said yes, and 51% have said no. For the second question, what should researchers do if their hospital does not have an institutional review board? The 3% have said go ahead and do the study first. 11% have said seek the help at the city level, and 24% have said register the trial with clinicaltrials.gov. While the third poll is coming up, Dr. Choi, would you like to comment on the first two questions, on the answers given?
Yes, thank you. So should randomized trials always be considered level 1 evidence? I would say the answer is no, because randomized controlled trials would always involve patient consent and explaining to some patients that they may be, let's say you're comparing a new drug with an old drug, or you're comparing a new drug with a placebo. So you have to explain this to each patient. And the patients may actually not consent to take part if they know that they're going to get a placebo. So regardless of how well you design your randomized controlled trial, there's always going to be some bias. There's always going to be some bias, because the bias is at the level of which patients will consent to actually participate in your trial. So I would say it's not always considered level 1 evidence. The second reason being that not all studies will lend itself to the design of a clinical trial. And we'll talk about some of that inside the lecture as well. So I'd definitely say no. With regards to the second one, if you don't have an IRB at your hospital, never go ahead and do the study first. That will really cause big problems later on, and you will not be allowed to do that anyway. Seek help at the city level, yes, because you've got to go to the higher level authority in order to ask them to review your protocol and allow the research to take place, and then register the trial with clinicaltrials.gov. So I would say the answer to this one is B and C. So that's the 57% of people agree seeking help at the city level and registering the trial. And should clinicians be doing research? Everyone says yes. I would add to this answer, actually, clinicians should be doing research, but not alone. I would say most of the time you need a multidisciplinary team. This would include epidemiologists, statisticians, and people who are very adept at writing research protocols and knowing what to do. Otherwise, if the clinician is not sure how things are done and they don't have a multidisciplinary team, oftentimes they start trials and they never get finished. In that case, patients and other people, collaborators in the team will become disillusioned and think it's a waste of time, and it will turn people off participating in your research. Thank you.
Thank you, Dr. Choi, for your comments.
Okay, Fauzier, I'll take over. Okay, I'm Soichiro Obara from Japan, so I'll moderate the next speaker's lecture. Okay, and next, please. I will introduce the next invited speaker, Professor Dong-Kyu Lee from Republic of Korea. Professor Lee currently works as a cardiothoracic anesthesiologist at the Dong University Ilsan Hospital. He is an expert in biostatistics and currently supports the Korean Journal of Anesthesiologists and Anesthesia and Pain Medicine as a statistical editor, reviewer, and statistical round member. Actually, I think the statistical rounds in the Korean Journal of Anesthesiologists, KJA, is very good for you to refer to when you would like to learn epidemiology and biostatistics. Also, his major areas in research are hemodynamics, respiratory care, intraoperative bronchoscopy, airway management, and biostatistics. He published several editors about biostatistics. Okay, today he kindly gives us a lecture as how to build a primary endpoint. Before streaming his lecture video, let's answer his poll question. The first question is, the primary endpoint, the most critical result among these endpoints, is not just about numbers. So, kindly identify the incorrect statement from the following. Choice A, it's useful to present confidence intervals and effect sizes in addition to p-values. Choice B, a smaller p-value indicates a more significant difference. Choice C, a statistical significant difference does not guarantee clinical significance or relevance. Choice D, minimal clinically important difference, MCID, is a rational method of presenting clinical relevance because it's based on personal experience of intervention. Okay, let's try to answer. Ready? Can you show the results?
The result is up.
Okay. Sorry, I cannot see the results, so it's okay. Can you give some comments, Professor Lee? And so can you give the right answer for the first question?
Okay, thank you. The primary endpoint is critical in interpreting study result, and the p-value is an important measure, but it alone doesn't tell the whole story for us. The statement, a smaller p-value indicates a more significant difference, is misleading because the p-value only shows the probability of observing the data if the null hypothesis is true, not the size or clinical importance of the effect. Therefore, it is essential to consider the confidence intervals and effect size or MCID along with the p-values to fully present the statistical and clinical relevance of the result. Thank you.
Okay, thank you. So he will give the lecture about the MCID later. Okay. Uh, let's move on to the second question. Okay. When planning research, the primary endpoint and the required sample size play a crucial role. So kindly identify the correct statement from the following. Choice A, it's better to apply the high-end complex statistical analysis method to determine the pure intervention effect rather than using a simple and robust statistical method. Choice B, when calculating the required sample size, the effect size can be better determined from the results of similar articles rather than being determined from a pilot study. Choice C, effect size has a standardized unit depending on the measuring method, which can be used to compare the effect between similar measurement results from different articles. Choice D, we cannot evaluate the significance of the primary outcome using only statistical analysis. Clinical relevance and statistical significance should be considered to improve our appreciation of the primary outcome. Okay, the choices are kind of complicated, but try to answer and try to select the correct statement, please. Okay, sorry, unfortunately, I cannot see the prevailing answers. So, Professor Lee, can you kindly give some comments and also the right answer?
Okay. First of all, sorry for the long sentences and complex content. The answer is the last sentence is correct. In research planning, we should consider both economical and ethical use of resources. While detailed granular information is beneficial for scientific purpose, but more general results are often sufficient for the clinical decision making. Simple and robust statistical method can provide strong clinical evidence with limited resources. And effect size is a standardized, unitless, and interchangeable statistic based on sample size and significance level and statistical power. As an estimated value, it includes confidence intervals representing a margin of error. Therefore, it is crucial to determine the effect size using accurate background information. So the correct one is the last sentence only. Thank you.
Thank you, Professor Lee. So, okay, we can go forward to the streaming the video lecture by Professor Lee.
Thank you for the introduction. Hello everyone, I'm Dong-gyu Lee from Dongguk University in Korea. There is no COI to report. Today we are going to dive into setting up primary endpoints with a special focus on the statistical elements involved. I actually spoke about this same topic at the last ASPA. I was lucky enough to meet an incredible colleague there, Professor Soichiro Obara. Thanks for inviting me to this wonderful webinar, and a big thanks you to Professor Obara for giving me the chance to discuss this topic with all of you today. The major things changed from my last talk is now we have 2 articles on effect size and MCID explanation. The right one on effect size and MCID was published a month ago. This has a beautiful supplementary material that covers the manual calculation of effect size MCI and MCID with sample data. I'm sure these articles will provide the detailed information on today's subject. Please find and read these articles for your future research material. Okay. In conducting a clinical trial, various outcomes may result from the interventions. Among these, the result of particular interest are commonly referred to as endpoints. For instance, in a study examining remimazolam's effect during monitored anesthesia care, while remimazolam sedates patients, it can also cause side effects like hypotension and respiratory depression. We choose one specific outcome from these to serve as the endpoint and measure its magnitude with a designed method. Then, using the established primary endpoint, we compare the effects between the control and intervention groups to provide decision-making evidence. To present the result of this comparison, we should report the magnitude of the difference and clarify the clinical significance of the observed difference. Statistically, these key points are articulated through measured differences and an evaluation of the statistical strength and limitations. However, our goal in analyzing the primary endpoint comparison statistically is to ascertain the clinical relevance and scientific robustness of the result. Let's discuss how we can achieve these objectives. When you plan a clinical research study, we start with an idea. Next, we create the study design and protocol, then collect the data. After that, we do the analysis and get the result. The statistical process also has several steps. First, we make a hypothesis from the idea. Then, we decide how to measure the main outcome, make a database with the collected data, do the planned statistical analysis, and finally interpret the result. The last part of the process connects the measured difference, strength, and limitations. We can show the strengths and limitations using statistical power and significance, which we already know. But how do we show the measured difference, and how do we understand it from both clinical and statistical views? Anyway, let's quickly go over the ideas of statistical power and significance first. The term statistical significance is true statistical term. It does not have any clinical meaning. We use this term only when statistical testing of the null hypothesis gives us a very low probability. It's all about the numbers with no clinical meanings. As you know, we find statistical significance through a null hypothesis significance test. This method involves setting a minimum effect size of interest. Then, we calculate the chance of seeing the measured difference by log and decide whether it's statistically significant. Significance testing gives us a simple yes or no answer about whether the observed difference is likely due to chance. Strictly speaking, the result of a significance test only gives us a yes or no answer. So we should not interpret the p-value as showing whether the observed difference is significantly more or less different from the null hypothesis. It simply tells us if it's the same or not. Because we set one minimum difference to calculate the probability, p-values cannot be compared with each other. A p-value of 0.01 and 0.04 can both show statistical significance, but we cannot compare them. We need to set a new difference based on statistical power to do that. Okay, the next issue is statistical power. As you already know, statistical power is greatly influenced by sample size. This diagram can be confusing. We can define type 1 and type 2 errors based on the difference in reality and statistics. Type 1 error is caused by the fault by statistics for the null hypothesis. Type 2 error is the result of the fault by statistics for the alternative hypothesis. Actually, these two types of errors are based on probabilities. They arise from the overlap between the probability distributions of null and alternative hypotheses. Also, the overlapping area of the probability distribution is determined by the minimum effect size we set and alpha and beta error rates. If we increase the sample size while keeping everything else the same, the spread of the probability plot gets narrower. This reduces the chance of both type 1 and 2 errors. That's why most researchers prefer to have a larger sample size. Then, let's move on to the major difference. Statistical power and significance mainly describe the statistical properties of the result. We need a scientific method to describe the clinical properties. For this, I recommend using the effect size. The effect size was first proposed by the statistician Cohen. It's a standardized estimate of the measured treatment effects. There are many types of effect size depending on the statistical method. The most popular one is Cohen's d for comparing two means. Effect size is standardized, so it does not have any unit. Unlike the p-value, we can directly compare effect size with each other. You can see examples of effect sizes. You can easily calculate these using functions in statistical analysis software. Also, some effect size can be converted into others, allowing us to compare effects from different statistical analysis methods. Interpreting Cohen's d effect size can be challenging. Cohen's d shows the mean difference in terms of standard deviation unit. For example, a Cohen's d of 0.5 indicates that the mean value of intervention group is half a standard deviation higher than the mean of control group. This means that approximately 69% of the samples in the control group would fall below the mean of the intervention group. The direct interpretation of Cohen's d is too complex and hard to understand. So the Cohen's effect size series provides a useful guide for interpretation. According to the magnitude of the effect size, we can categorize them as small, medium, or large effect. You can also make comparisons by looking at effect size between different groups or conditions. This helps to understand and communicate the effect size in research findings more intuitively. Effect size is better than the p-value in some ways, but since effect size is also based on statistical difference, it does not have any exact clinical meaning. even if we get a large effect size, a large measured difference in numbers does not always mean clinical importance. It's important to consider to clinical relevance and context when interpreting the size of a measured difference. Until now, we've focused on the finding clinical relevance through statistical analysis, especially by looking at statistical power. Statistical power is important because it shows a study's ability to detect a true effect if there is one. By making sure we have a big enough sample size and using the right statistical method, researchers can increase their study's power and improve the chance of finding clinical relevant difference. It is important to remember that statistical power alone does not guarantee clinical relevance. Clinical relevance includes statistical significance and things like the size of the effect, patient perspectives, and practical implications. The most clinically relevant part of statistical power is the effect size. In many studies, researchers determine the effect size by looking at results from similar previous studies, doing pilot tests, or based on their own goals. However, we need to consider the scientific validity of these decisions. To establish scientific validity, we use various methods to define clinical importance as shown in this slide. However, linking these definitions of clinical effects to their real significance for patients can be challenging. Defining the clinical relevance of a measured difference means considering factors beyond just statistical significance. So, some statisticians and researchers have introduced methods that establish meaningful connection between statistical measures and clinical aspects. There are several terms used to define clinical relevance, like MCID, CMD, MIC, and MCII. These terms have similar but slightly different definitions of what counts as a clinical relevant difference. By defining these clinical relevance criteria before starting the research, researchers can design their studies to detect meaningful effect and make clinical meaningful conclusion. This process ensures that the study findings are relevant and useful in a clinical context. One of the most popular methods is the minimal clinically important difference, MCID. It defines the smallest meaningful changes from an intervention by looking at patient-reported outcomes or setting a statistically acceptable margin. Researchers then use a statistical method to show the clinical relevance of these changes. Studies to identify the MCID in specific contexts have rapidly emerged in the field of anesthesia and pain management. Currently, there are 4 recommended methods for determining the MCID. Among them, the triangulation method is considered a reasonable approach. It combines patient-reported outcomes with distribution-based indices and verifies the findings through statistical analysis. Here is a simple example. It's an example of a pain score. From a representative sample patient, we can get the VAS score and a patient-reported outcome at the same time, such as the global assessment rating scale. You can see an example of a global assessment scale. Then check the correlation between them and perform statistical analysis like the Yoden index, ROC analysis, or mixed modeling. Based on the statistical analysis result, we can choose a clinical relevant MCID. However, the MCID approach has several limitations. It is inherently subjective, meaning that even in small similar situation, it may not be easily replicated. Additionally, determining MCID is based on statistical method, making it prone to biases from factors like sample size and measurement errors. Also, because of its subjective and varied nature, the identified MCID can be highly sensitive to specific clinical situations. Therefore, when using MCID in research or applying it to patient care, it is important to be cautious and consider these limitations. MCID should not be applied blindly or simplistically. It's crucial to interpret and use MCID findings thoroughly, considering the individual characteristics of the patient population and the complexities of the clinical settings. Now, we can partially address the clinical property area by using effect size and MCID. Effect size and MCID are currently the best methods we have to describe clinical impact and relevance. However, we need further advancements to better define clinical relevance. In summary, the primary endpoint serves as evidence for decision making. It's a specific outcome supported by both statistical significance and clinical relevance. Statistical significance indicates result based on a binary decision-making process, while effect size and MCID can express clinical relevance. I encourage all of you to consider use effect size to describe a statistical analysis result in your research paper. By including effect size measures, you can help the broader scientific community understand and make meaningful comparisons across studies. Thank you for listening.
Thank you, Professor Lee. That's a great lecture, actually. So we need to move on to the next lecture. So I would like to introduce our next co-moderator, Professor Hector Rai. Professor Hector Rai is currently working for the Department of Anesthesiology at Christian Medical College at Vellore in India. Also, she has been working for many anesthesia societies, which includes the education committee at the WFSA. So her main interests are in pediatric anesthesia, pediatric thoracic anesthesia, pediatric regional anesthesia, focus and simulation and education. So Hector, I will hand over to you.
Thank you so much, Dr. Soichiro. It is indeed my pleasure and honor to introduce Prof. Kazuyoshi Aoyama, and I take pride in actually introducing him to you guys. He is staff anesthesiologist at Department of Anesthesia and Pain Medicine at Hospital for Sick Children. He works as associate scientist at Child Health Evaluative Sciences at Sick Kids Research Institution. He has got special interest in pediatric perioperative outcomes and perinatal health. I would like to introduce the poll questions for the delegates. Can I have the poll questions, please? Okay. So question number 1 is a narrative review part of evidence synthesis studies? Yes or no? Which of the following, question number 2, which of the following is an associated adverse outcome of pediatric tonsillectomy? Pain, post-operative nausea, vomiting, emergence delirium, all of the above. Question number 3, is intravenous dexamethasone associated with reduced opioid requirement in pediatric tonsillectomy? Yes and no. Can we have poll answers, please? All right. So interesting. 71% of our delegates feels narrative review part is an evidence synthesis studies. We 71% people feel all pain, PONV, and emergence delirium are the part of adverse outcomes for tonsillectomy. And for question number 3, 84% of the delegates feel that intravenous dexamethasone is associated with reduced opioid outcomes requirement in pediatric tonsillectomy. I think with this poll results, I will just ask Prof to, give his insight, and over to you, Prof.
Thank you, Hector. Hi, everyone. So for the first question, my answer is no. In my view, evidence synthesis studies has 3 main methodology. One is scoping review. The second is systematic review. And then third is a systematic review with meta-analysis. I will explain the detail of these methodology in my lecture, but narrative review is not included in evidence synthesis studies because it doesn't have a robust methodology to do it. That's my answer to first question. The second question is, the answer is all of the above. So the pain, postoperative nausea, vomiting, and emergency delirium are all associated with pediatric tonsillectomy. These are known as a risk factor. Sorry, the pediatric tonsillectomy is known as a risk factor, all of them. So I will explain, and then also how we can address these outcomes in our practice too. The last question is intravenous dexamethasone associated with reduced opioid requirement in pediatric tonsillectomy? The answer is yes. We recently conducted a systematic review with meta-analysis to answer this research question. And then we included 16 clinical trials and then found out intravenous dexamethasone significantly reduce opioid requirement in pediatric tonsillectomy. Back to Hector.
Yeah. Prof, you can carry on with your lecture.
Sure, thank you. I will move on the lecture.
Video. Yeah.
Hi everyone, my name is Kazuyoshi Aoyama from Department of Anesthesia and Pain Medicine, Hospital for Sick Children, University of Toronto. Thank you so much for inviting me to join ASPA Flex webinar series today. I'm very pleased to talk about the pediatric perioperative outcomes research. I receive several research grants and awards to operate my own research program. Also, I serve as an editor in these peer journals. However, none of them impacts on today's presentation. Main objective of my talk today is to learn key topics in pediatric perioperative outcomes research. Other objectives are following on the right side. First, to learn major outcomes in pediatric perioperative medicine. Next, to understand roles of evidence synthesis studies in pediatric perioperative medicine. Last, to know future research implication in pediatric perioperative outcomes research. These are contents of my talk for next 20 to 25 minutes. First, I will introduce major pediatric perioperative outcomes. Then, I will explain why evidence synthesis studies are important in pediatric perioperative outcomes research. Next, I will present recent study findings of my own evidence synthesis studies as examples. Then, I will talk about what future research needs to be done in pediatric perioperative outcomes research. Last, I will summarize my talk as take-home message. Okay, let's look into major pediatric perioperative outcomes first. This systematic review was conducted by the Pediatric Perioperative Outcomes Group in United States. The authors explored what type of outcomes were reported in clinical trials of pediatric perioperative research. The table on left bottom summarizes their finding. They divided study into 4 different age categories: neonates, infants, age 1 to 12 years, and then older than 13 years old. Each row represents what type of perioperative outcome was reported in each study. Their finding is patient comfort is the most common outcome among infants and older children. On the other side, clinical indicator is the most common outcome in neonates. And then these clinical indicators are second or third common in infants and older children. Within patient comfort, the most common outcome was pain, and then second was PONV, post-operative nausea vomiting, and then third common was emergency delirium, ED. In clinical indicators, the most common outcome was perioperative respiratory adverse events, PRAE. So these 4 outcomes, pain, PONV, ED, PRAE, are major outcomes in pediatric perioperative medicine. Now you understand major outcomes in pediatric perioperative medicine. In my research program, I use various research methodology to investigate pediatric outcomes and also outcomes of critically ill pregnant women. In the past, I work with excellent fellows. Now they are attending staff in children's hospital worldwide. My research program usually has several members, 3 students at the moment, and 4 to 5 fellows, including a postdoctoral fellow. We currently work on several projects that investigate pediatric outcomes using evidence synthesis. Next, I will explain why evidence synthesis studies are important in pediatric perioperative outcome research. You may have seen this type of figure before. This figure shows level of research evidence. Basic research develops foundation of research evidence. This figure doesn't mean basic research is more important than clinical research and vice versa. This figure means the higher the level of research evidence, the more influential it is on clinical practice. So we often refer to systematic review with meta-analysis and randomized control trial to change or modify our clinical practice. My friend and colleague Dr. Jason Hayes published a very neat study in Canadian Journal of Anesthesia recently. He investigated how fragile RCTs in pediatric anesthesia are using fragility index FI. Higher FI indicates more robustness of the results of RCT. I would refer you to this actual paper to understand how we can calculate fragility index, but I will explain his findings. He found RCT in pediatric anesthesia has low FI, which means small number of outcome events needs to change to non-events to render significant p-value non-significant. This is a fragile results. He also found RCT in pediatric anesthesia are underpowered. That means increasing false negative, failure to detect true effect. One way to mitigate these challenges is to increase sample size by synthesizing randomized clinical trials with meta-analysis. That's why my research program conducts evidence synthesis studies in pediatric perioperative outcome research. Next, I will explain my view of evidence synthesis studies. Basically, evidence synthesis studies are different from narrative reviews because we need to conduct evidence synthesis studies with robust methodology. Robust methodology includes, but not limited to, research questions, protocol registration, systematic literature search, qualitative and/or quantitative data synthesis in each project, and quality assessment. There is an established way to conduct evidence synthesis studies using robust methodology, including these points. That's why this is way different from narrative reviews. This table summarizes my view to define evidence synthesis studies. In evidence synthesis studies, there are three major methodologies: scoping review, systematic review, and systematic review with meta-analysis. Meta-analysis happens always with systematic review. In terms of a question, in scoping review, research question can be broad, or you can develop multiple research questions in scoping review. In systematic review and systematic review with meta-analysis, research question needs to be very specific. In terms of data synthesis, scoping review and systematic review usually employ qualitative data synthesis approach. On the other side, systematic review with meta-analysis can employ quantitative data synthesis to pool effect size among eligible studies. You may have heard about rapid review. In rapid review, you can skip some steps of systematic review so that you can conduct rapid review very quickly. So that's why it's recognized as semi-formal way of systematic review. In systematic review with meta-analysis, you can compare one intervention with one control or another intervention. It's called one-to-one or head-to-head comparison or pairwise comparison. In network meta-analysis, you can compare more than two interventions. So that's the feature of network meta-analysis compared to systematic with meta-analysis. So this is an advanced way of meta-analysis. Next, I will introduce two recent study findings from my own project. One is systematic review with meta-analysis. The other is systematic review with network meta-analysis. The first project is effects of dexamethasone on opioid consumption in pediatric tonsillectomy. We use a systematic review with meta-analysis to conduct this project. As you know, tonsillectomy is a common procedure in pediatric population and very painful. Adverse effects of opioids are more pronounced in severe OSA population, so minimizing the use of opioid is important to avoid these respiratory events. Dexamethasone is known to reduce morbidity in pediatric tonsillectomy and has evidence as a pain adjunct. However, it is unknown whether dexamethasone can reduce opioid consumption in this procedure. So we hypothesize dexamethasone reduce perioperative opioid consumption in pediatric tonsillectomy without increasing postoperative hemorrhage. Again, study design was systematic review with meta-analysis. We conducted systematic literature search on 5 databases. The population of this study was children younger than 18 years of age undergoing general anesthetics for tonsillectomy with or without adenoidectomy. Intervention was IV dexamethasone. Control was placebo. Primary outcome was perioperative opioid consumption in oral morphine equivalent, OME milligram per kilo. Secondary outcomes included postoperative hemorrhage and PRAE. We conducted pairwise meta-analysis with random effect model to compute mean difference MD for the primary outcome and risk ratio RR for secondary outcomes. We also conducted meta-regression to investigate dose-dependent effect of dexamethasone on these outcomes too. This table summarizes findings of our project. In the primary outcome, we found statistically significant absolute reduction of 0.11 milligram per kilogram OME, which is equivalent to 20.6% relative reduction of OME in pediatric tonsillectomy using IV dexamethasone. However, we didn't find any dose-dependent effect of dexamethasone on opioid consumption. Please note that we found administrative doses of dexamethasone among eligible trials range from 0.1 milligram per kilo to 1 milligram per kilo. Secondary outcomes showed dexamethasone didn't increase the incidence of postoperative hemorrhage. These outcomes were supported with certainty of evidence using grade, moderate to high quality of evidence. The current systematic review of 16 RCTs in pediatric tonsillectomy found consistency with previous studies that dexamethasone decreased pain after pediatric tonsillectomy. We also add the new evidence of quantitative reduction in opioid consumption. This reduction in opioid consumption may reduce morbidity in higher risk patients with severe OSA, which needs to be confirmed in future research. Also, future research is warranted to find a minimum effective dose of dexamethasone as pain adjunct too. We concluded the current study is the first to ascertain the quantitative effect of dexamethasone on opioid consumption in pediatric tonsillectomy, and that dexamethasone results in a 20.6% relative reduction of perioperative opioid consumption compared to placebo without increasing the incidence of postoperative hemorrhage. The next project is dexmedetomidine versus TIVA in pediatric emergency delirium. We employed systematic review with a network meta-analysis to conduct this project. The main objective of this project was to indirectly compare the effect of TIVA and dexmedetomidine on the incidence of pediatric emergency delirium. Again, our study design was systematic review with network meta-analysis. Population was children younger than 18 years of age undergoing general anesthesia. Intervention was intraoperative dexmedetomidine as adjunct to sevoflurane-based general anesthesia. Comparison was TIVA with propofol and narcotics. The primary outcome was incidence of ED. Secondary outcome are following. I just want to explain briefly how network meta-analysis works in this project. Before we conduct this project, we knew there were RCT with direct comparison between sevoflurane and sevoflurane with dexmedetomidine. And also we knew there were RCT with direct comparison between sevoflurane and TIVA. However, we also knew there was no RCT with direct comparison between TIVA and sevoflurane and dexmedetomidine. So that's why we employed network meta-analysis, which allow us to compare sevoflurane with dexmedetomidine and TIVA through the common intervention group of sevoflurane. Out of 3,000 studies, we found 30 studies that compared sevo with dexmedetomidine, while 36 studies compared sevo with TIVA. This table shows forest plot of direct comparison and indirect comparison between TIVA and sevo with dexmedetomidine. We employ Bayesian method instead of a frequent test. So here we showed risk ratio with 95% credible interval instead of a 95% confidence interval. The main finding was sevo with dex was associated with a trend towards lower incidence of ED compared to TIVA with low quality of evidence. Risk ratio was 0.88. 95% credible interval was 6.61 to 1.2. The main finding of this network meta-analysis was from subgroup analysis. Effect size on ED found to be larger with high dose, which is greater than 0.5 micro per kilo of dexmedetomidine. That shows risk ratio relative to TIVA was 0.66. 95% credible interval was 0.42 to 1.0. The current systematic review with network meta-analysis found dexmedetomidine adjunct to sevoflurane and TIVA are equivalently effective in preventing ED without difference in emergence extubation times compared to sevoflurane only. In terms of clinical implication, children undergoing general anesthesia may be better to receive intraoperative dexmedetomidine greater than 0.5 micro per kilo as adjunct to sevoflurane to decrease incidence of emergence delirium. We concluded the current study was the first to ascertain the quantitative comparison of dexmedetomidine with TIVA and their effects on emergence delirium in pediatric anesthesia. Next, I will discuss future research topic needs to be covered in pediatric perioperative outcomes research. As I mentioned at the beginning of this talk, the major outcomes of pediatric perioperative outcomes research are pain, PONV, ED, and PRAE. As you know, pediatric tonsillectomy is known as a risk factor of each outcome of these 4 outcomes. That's why we thought pediatric tonsillectomy needs to be more studied. First, then we conducted a systematic review of clinical practice guidelines for pediatric tonsillectomy to understand what's recommended with the existing evidence. And then this project generated several research questions already, like in terms of opioid consumption in the context of a pediatric tonsillectomy, how we prophylactically prevent PONV in pediatric tonsillectomy, and also we need to find out best way to prevent emergency delirium in pediatric tonsillectomy too. In terms of research methodology recommended for future pediatric perioperative outcome research, we found existing evidence lacks biological sex difference perspective in their evidence. So for the future research of pediatric perioperative outcome research, we should incorporate biological sex difference perspective into the project. And then in evidence synthesis studies of pediatric perioperative outcomes research, either pairwise meta-analysis or network meta-analysis with individual patient data is ideal, which enable us to adjust more confounding in the analysis. Our program found regional anesthesia is getting more evidence in terms of pain management in pediatric perioperative outcomes research. As you know, remimazolam is a new sedation or general anesthesia in pediatric anesthesia. There was a new RCT that compare remimazolam with other agents in incidence of emergency delirium. I think there will be more study that explored the role of remimazolam in emergency delirium in the future too. At this moment, as a prophylaxis of PONV in pediatric perioperative outcomes research, we don't know best combination of anti-anemics yet. This topic needs to be investigated more detail in the future too. In terms of a PRAE, in our previous project, we realized different RCT employed different or various definition of PRAE, which prevent us from synthesizing the results across the trials. So in the future, PRAE needs a standardized definition for quantitative data synthesis. This is my slide, which shows a take-home message from my talk today. Pediatric perioperative outcomes research has 4 major outcomes: pain, PONV, ED, and PRAE. Evidence synthesis has important roles in pediatric perioperative outcomes research because evidence synthesis studies enable us to conduct quantitative synthesis to increase sample size in fragile RCTs of pediatric perioperative outcomes research. Future research area will be pediatric tonsillectomy, and there is growing but not well summarized evidence in regional anesthesia in terms of pain management of perioperative outcomes research. Thank you so much for listening to my talk. Any inquiries for research collaboration are always welcome. Please contact me at this email. Thank you.
Thank you, Prof. Indeed, difficult topic and very well addressed with your own examples and your own researches. I think quite a good insight into evidence synthesis studies. So thank you all the 3 speakers, Dr. Choi, Dr. Lee, and Dr. Kazuyoshi Aoyama. Sorry for your. So I think I'll just begin with the first question, and the question says, yeah, okay. So it is maybe Prof. Choi, you can take over this question. And the question goes like, if somebody has to conduct research about the drugs, especially when they're trying to compare it with the placebo for children, are they going to face some challenges when they're facing IRB? What is your insight, especially, for analgesic drugs?
Okay, thanks for that question. For the IRB, they're definitely going to face some challenges. They won't allow for such trials to go ahead if there's already a well-used and proven effective drug. So the best thing you can do really is just to compare your new drug to the old one or the existing one, and do maybe a non-inferiority trial or a superiority trial. But there's definitely they will not be able to run such a trial on a placebo if there's already well-proven treatment for this, especially if it's pain and especially in children.
Sure. Yeah. Thank you. Prof. Fauziya, you would like to add something to it?
Yes, thank you, Ekta. Yeah, I completely agree with Dr. Choi that if there is a standard treatment available, especially in study of pain, then it will be impossible to get the approval from IRB. But there are some examples in anesthesia where this can be done. For example, pre-medication in daycare cases. That's controversial. So some institutions do give pre-medications in pediatric daycare cases. Some don't because there is no standard for that. So in those cases, it may be possible to do this kind of a trial, but certainly not with the perioperative analgesia. Thank you.
Thank you.
Can I again ask Dr. Choi? One of the problems, especially in LMIC, where the workload the clinical workload is very high, is to get our younger colleagues interested in research. So how do we motivate and how do we encourage them in this? Any ideas about that? Or other panelists can also come into it. They can give their
I think everybody, thanks for that question as well, because it is difficult to get people interested in research. I would say the best motivation is that the work will be acknowledged, it will be published. The junior colleagues may be able to showcase this in like webinars like this, or even attend a conference, maybe an overseas conference, and they would be able to get academic or professional leave to do that. Once they know that there's an endpoint, something will happen if they get interested in the study and help in the study, then I do actually think that that's the biggest incentive. As I was just saying in the talk, it's just that a lot of studies get started and they don't get finished. A lot of studies just tail off or takes a really long time to get finished. Like maybe you got involved as a trainee, and by the time you're consultant, it's still there, it's not finished, right? So I think with that, it actually puts people off because they can't see an endpoint, they can't see any results. So I would say, if you're trying to get trainees at the beginning to be involved in the study, don't make it too ambitious, and really be very clear with where they're going with this. It's the same in academia. Like when I was a junior, oftentimes the big professors will be involved in trials and studies, and the juniors who have to do a lot of the work, we don't actually get any acknowledgement. We might not even get our name on the paper, and definitely not near the front of the paper. So that's quite discouraging. So I think in order to get the trainees to be involved, it's really important to reiterate to them that you'll be acknowledged, your name will be on this paper, where it will be, and to have this upfront, and that will be a big encouragement.
Thank you.
Yeah. So how about in your institution, Professor Lee and also the Professor Aoyama? We would like to ask the same question to you both. How do you try to engage? How do you try to encourage the young clinicians to conduct clinical research in your department? Professor Lee, about your institution?
Actually, it's really a big problem in Korea and my hospital also. Actually, in Korea, we have on strike on the government policies. So all clinical studies are all stopped for 2 months. That's a really big problem. So the junior professors usually get all studies, processings, and do the clinical practice is really hard. But I try to share, but it's very hard to perform sharing because sometimes I possess him. That's the problem. So I think manpower, the numbers of researchers is big issues for solving these problems. But these days, very hard days for us. So actually, usually the trainees exist, then we do many things, very simple things to do the trainees, but it's sometimes very uh, inconvenient because the trainees didn't understand, uh, doesn't understand the studies outcomes and studies processes. So I think the best method is frequent study meeting and frequent compensations for that is the best method for encouraging them.
Thank you, Professor Lee. But when I attended the last meeting in Seoul, the Korean Society of Anesthesiologists, I was actually very surprised because the Korean Society of Anesthesiologists provided many opportunities to educate the biostatistics and so the epidemiology at the annual conference. I was very surprised. It was very good for the young clinicians. So how do you try to arrange the such educational opportunities in your societies?
Uh, Usually, the many clinical society of anesthesiology, we have several sub society of anesthesiology. Each society try to supply some statistical or methodological ideas for the clinical researches for young faculties, and it started from 5 or 7 years ago. Maybe it will have some good 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 result within few years, I guess.
You're muted, Dr. Soichiro.
Professor Aoyama, thank you, Professor Lee. So, Professor Aoyama, it seems that the environment around conducting clinical research in your institution would be ideal for young clinicians because your subordinates, such as clinical fellows and the students, seem to be involved in your research projects. So, how do you try to encourage and so how do you try to involve the young clinicians in your research project?
So you're muted, Professor.
I'm sorry. Now, can you hear me now?
Yes.
Yes.
Sorry. Yeah, so my hospital is academic children hospital. So every faculty, like a staff, needs to do academic staff on top of a clinical practice, right? But the academic staff or academic project doesn't need to be research. It can be like a quality improvement or education too. So when they become a staff or faculty of the University of Toronto, they have to choose which pathway they are going for. So, and then education can be presented at the conference or can be published a narrative review somewhere. So it can be a part of research, and also QI can be a part of research too. So because our hospital is academic children hospital, so everyone has to do academic project that could lead to the publications somehow. So for young faculty, they have to choose their own pathway and they do some academic project as they go on their pathway. For the clinical fellows, it's very unique at here at SIG Children because we are very generous for our clinical fellows. So the clinical, so we have 12 clinical fellows per year, but each clinical fellow has 1 academic day per week. So our strategy is a bit incentive first. And then we will try to get them involved in any academic project, a new project or ongoing project. Sometimes they join QI or just a teaching educational project too. It doesn't need to be research project, but somehow it should be academic. And then once we give them like an incentive first, they just continue. Because if they don't continue, we will take out the academic day. So they don't like to lose their academic day, right? So our strategy is a bit unique, and also I think it's been working well so far. Oh, sorry, one last answer to your question, Dr. Obara. In terms of medical student or undergraduate students, like a research involvement or research publication on their resume or CV is very important when they apply for residency later on or medical school later on. So they are very keen on the research environment. So for example, every year I receive like around 15 inquiries from the student to get the summer student spot, but I can offer only 1 or 2 every year, right? So it's very competitive only at my stage, my program too. So. Sorry, did I answer your question?
Yes, yes, yes. That's what I want. Thank you very much. Thank you,
No
Professor
problem.
Oyama. Yes.
Do we have a little time, Dr. Barra? I can.
Yes, please. Yeah,
yeah.
you can go ahead.
Just taking it from Professor Ayoma, you know, one of the problems, I'm again bringing up the low middle income countries and the lower income countries because there are quite a few in Asia. The problem here is that, you know, most of the research in anesthesia is related to drugs or new monitoring or, you know, new things. And by the time these things appear in LMIC, the research in high income countries has already been done on these things. And researchers in such countries really can't compete because they're mostly restricted to observational studies or surveys. Now, the problem with those is that they're more locally focused. Even the quality improvement studies are more focused to the environment that they're in. And it's very difficult to get them published, especially in good journals. So I would like to have your comments on that. And maybe I can give the example of the journal Anesthesia and Analgesia from USA, who have a global section now. And it is possible to get studies like this from LMIC published in that section. So a small, just 1 or 2 papers in each issue from these countries, because that will give a boost to researchers from these countries to see their name in a good journal. Thank you.
Yes, that's very good question point, I think. I'm serving as editor, section editor of Peds Anesthesia and Journal of Anesthesia too. So honestly, when I submitted the papers from such a countries, sometimes, not always, sometimes evidence already exists. So from editorial point of view, it's hard to proceed or like send it to a peer review because we know there's evidence, but it may be new to their country. So what I usually do is to encourage them to find out a local peer journal in their country. It may be a high impact journal, but it's still important and relevant in their context. So I still encourage them to keep publishing or keep trying to submit to a local journal. Then I know it's hard to publish it in the high impact journal, but I think it's still important to publish it to their peer in their context or in their countries. So that's how I usually respond to such a situation.
Thank you.
Thank you, Professor Oyama. So it seems that we need to close today's webinar. Teddy, can you go back to the slides? Yes. So before closing, I want to announce some stuff. As we initially informed, we are very pleased if you kindly had any interest in this multi-center collaborative research project, Teaching Teacher Study. Your participation is highly appreciated. Next, please. So also, the ASPA has been trying to collaborate with the research group in other regions than Asia. The European Society of Anesthesiologists has been proceeding this prospective observational research looking at major complications during tracheal intubation in children undergoing general anesthesia. They are currently recruiting as many patients all over the world. So kindly scan the QR code if you are interested in joining this research project. Okay, next, please. Next ASPA webinar is supposed to be organized by our pain special interest group. The webinar features essentials of pediatric pain in trauma in August. So kindly scan the QR code to register the upcoming webinar. Okay, next please. So also the ASPA celebrates our 20th anniversary scientific meeting next month in July in Malaysia. Our friends in Malaysia has been trying to organize and prepare the fabulous academic meeting. Kindly join our meeting. Without doubt, to be sure, to be honest, I am sure that the meeting is one of the best anesthesia meeting all over the world, which celebrates and enjoys such diversity and inclusivity. Please come to join our scientific meeting. Okay, it's time to close this webinar. With a special best appreciation to all the speakers, moderators, IT support members, and all the attendees to contribute to this successful webinar. Please give your best applause for the distinguished speakers, and thank you again. See you all in the next webinar. Have a good Sunday and celebrate the Islamic events. Thank you all.
Thank you.